So this is the official start of the DoxyPEP implementation webinar. All systems go, question mark. I want to thank my partners and collaborators at the National Coalition of STD Directors for working with us on this webinar. Thank you so much. Kate, if you want to pop off mute and put yourself on video and say hi, that would be great. My colleague Kate Shea from the coalition.
Yes. Hi, everyone. Hi, my name's Kate. My pronouns are she, her. Really excited to be here today in collaboration and representing NCSD. You'll hear from me a little bit later, but really excited to get these perspectives and be a part of this.
Thanks so much. And again, thank you for all your help in working on this webinar today. So when you registered, we asked you questions. If you had any questions and if you wanted to share your hopes or concerns about DoxyPEP, I'm not going to go into all of these directly, but here is a snapshot on the left of some of the hopes people shared. Everything from being excited to have a new tool that's safe and effective at reducing STIs, to providing options for people that lead to less anxiety and worry, more sexual freedom and pleasure. The fact that this Doxy is accessible and affordable. So there was a number of things that you all said, and I want to just really highlight this has been a very popular webinar. We have had now over 566 registrants from 39 countries have registered today. This will be in our top 2 webinars of all time in terms of registration numbers. And here are some of the concerns that people shared when they registered. So you can see people were concerned about everything from resistance to how this is going to be funded, just exactly how effective this is. Will there be access to all the people who actually need it? So a lot of things came up in the audience, all excellent concerns. And hopefully we'll be able to address a lot of these in our conversation today with our panelists and speakers, but also hopefully you all can share information and thoughts and ideas in the chat as well. As I said, there are so many experts in the room, and all of you are experts in your communities and what you are doing. Here's just a snapshot of where all those 39 countries are. So this is a quick look at who is on the call or who registered for the call. I see we now have over 200 people live. And again, over close to 600 have registered. So thank you all for being here from every corner of the planet. And please introduce yourself in the chat if you haven't done so already. However you would like to do that, your name, if you have pronouns you want to share, where you're dialing in from, what organization if you want to share that. If you want to give us a weather update or what you have in your cup, I have coffee in mine. Please feel free to connect with each other in the chat now. And for those of you who joined a little early on these webinars, you know that DJ Jimberly is always spinning a specially curated playlist for the webinar. This is today's playlist. These slides will be sent to you. So if you should want to check out any of these songs on your own, you can check to the slides and double check on any of the names or artists that we featured today. And please join us for our next webinars. We have a couple in the offing coming up in November. So this one on November 15th, HPTN 096, Building Equity Through Advocacy, an integrated status neutral approach for ending the epidemic among Black gay men in the South. Super excited about this webinar. We'll make sure we drop the link in the chat so you can directly register from there. But we hope to see you in a little more than a month on Wednesday, November 15th. And then this was literally just finalized this morning. We have put out a save the date, please, for November 2nd. So actually sooner than the 15th. The TCA will be doing its second webinar on decolonization. And this time we're really excited to be collaborating with the O'Neill Institute for National and Global Health Law. So without further ado, we're going to move into our agenda. This is the order of speakers. We're going to start with Vaughn-Ogin, who represents Bigger Blacker Book, a sexual health app for gay and bisexual men, and is also a DoxyPEP consumer. We're then going to move on to Dr. Taimur Khan from Fenway Health. We then have a nurse practitioner, Kendrick Clack from Houston, who's going to share some perspectives, and we're going to end the formal presentations and discussion with Kate Shea from the National Coalition of STD Directors. Of course, we're going to be doing QA and discussion throughout. And once our sort of formal presentations are done, we really hope to continue to have lots of robust discussion. This is a 90-minute webinar. It will go for an hour and a half. So hopefully we will have time to have as robust a discussion as we can in that period of time. So I'm going to stop sharing my screen, and I'm going to see Lee. Have you joined us?
Yes.
Yes. I see. I'm going to put a spotlight on you for a second. There you go. Good morning, Lee. Let me, if you want to quickly introduce yourself, I'm going to pull up my notes.
Sure. My name is Lee Vaughn-Ogin. I was creator of the Bigger Blacker Book, which is a sexual health tracking app for gay and bisexual men. I live out in Seattle, and I've been using DoxyPEP for about a year or so now.
Excellent. Thank you for that. So we're going to start off this webinar, everybody, with a little bit of Q&A. We're not doing slides here. We just want to ask Lee some questions, and I'll be paying attention to the chat, and hopefully we'll have a few minutes to see if anyone else wants to ask a question outside of the ones I'm asking. So first, Lee, tell us, how did you first hear about DoxyPEP?
It's a little strange, actually. One of my exes had brought it up that they had been on part of a study that was allowing them to try taking an antibiotic as a PEP treatment. And I heard about it and I was interested, and then another friend of mine had mentioned about the study, and so I reached out and tried to find how I could get on the study as well. And that's when I heard about the trial that was going on.
And so when you heard about it and you decided to get involved, what kind of concerns and questions did you have about DoxyPEP?
I was worried about whether or not it would be antibiotic resistance. I was worried about whether or not I could tolerate taking an antibiotic, but I was really looking for something that could help stop the number of STIs that I had been picking up. It was a little bit of Russian roulette. You have no idea if you had something, or if every sexual encounter wasn't going to result in having an infection, and there was really no way you could stop it except treatment afterwards and constant testing.
So I think you're sort of getting into this now, but can you expound a little bit more on why you decided to take DoxyPEP?
I had been getting a number of STIs, and I wanted to find ways to try and cut that down, or at least prevent it, in a lot of the same way that I had been doing, that the PrEP was a treatment option. I had been hoping for something that would be similar that I could take, because at the moment, my only choices were I could go and get treated for what I thought was an infection, and then wait until the test results came back, and then it was either yes, I had a treatment, or no, I didn't need a treatment. So DoxyPEP was kind of I take it, and then I maybe don't have to take the treatment.
Right, exactly. That would, yeah, hopefully, right? We want to prevent from you ever needing to take a treatment in the first place. So far, what has been your experience, your overall experience taking DoxyPEP, including any kinds of, physical side effects you may have experienced?
So one of the things I've noticed was that it did indeed reduce the number of times that I had to go in for treatment. Even when some of the sexual partners that I had been with had actually been exposed to something, I didn't actually contract it. But there were some side effects. for instance, it is a lot hard. My digestive system is not happy with taking DoxyPEP. And it usually takes a number of days after I've taken the pill before my stomach will settle back down. I did notice that if I take a probiotic along with it, that it does help alleviate those symptoms, but that is definitely the big one.
Wow, so your kind of upset stomach lasts for days.
Yeah, it lasts for my boyfriend and I joke about it, but it lasts for about 2 days. That you are just not useful with your stomach.
So that's kind of intense. So in terms of other sorts of side effects, to sort of, I guess, balance that seems like kind of a big deal to me. Or what kind of mental, psychological, emotional side effects have you experienced taking Doxy?
Um, Mentally, it's kind of hard to put yourself in a position of you as a gay man, you need your digestive system to be working right. And you want to take this pill, but you know that this pill is going to result in a day or two of you not being able to do that. So that's kind of it it makes you a little resistant to wanting to take it because you know it's what it's going to do, but you want to take it because you know it's protecting you against. Um, I've not gotten any there wasn't any negative connotations to me taking it. In fact, people look at me as more sexually positive for having taken this medication that clearly shows that I am interested and engaged in my own sexual health.
That's right, exactly. Being super proactive about it. So this kind of gets into my next question. Do you talk to other people about taking Doxy? Your friends, family, colleagues. Clearly, it sounds like you talk to your boyfriend, your partner about this, but how, does this come up in other conversations? Do you talk about Doxy over, dinner or cocktails or coffee? What does that look like for you?
Um, in the same way that Doxy was presented to me by the people that I was around, because it was seemed like a wonder drug. This was the same for me. I tell everybody that I can that this is an option, that how good this is, that it really does work. And it allows you to be proactive about your sexual health because instead of you having to have sex, wait a week, go get tested, then find out if you have something and then get treated, you can try and mitigate that and take care of your own health. So it's kind of like, it's like PrEP, it allows you to take control of your health in a way that doesn't involve somebody else doing the right thing.
So in terms of, I'm just curious, and you can share as much as you want on this or not, but in terms of, since DoxyPEP is about after potential exposure, so a little different than PrEP, which is a daily practice for a lot of people. In terms of taking it after, how often do you think you're taking Doxy in a typical month or across a few months?
Well, according to my app, I take it about 2 times a week right now, 2 to 3 times a week.
So I'm glad you mentioned your app, and I meant to start that our conversation off with that. You have this app called Bigger, Blacker Book. Can you tell us a little bit about that app? And I know there's some new things on the horizon with it, so you want to share a little bit of information about that?
Sure. So the app is it allows you to track your sexual activity. It also allows you to track your STI uh, treatments and testing. But what its new feature is that it will allow you to also it'll also remind you, hey, you need to go and get treatment and testing. And also the new one is that we're after an encounter, which is anything that any kind of sexual encounter that you have, will notify you in 48 hours that you have another 24 to go and take your doxy. So the doxy reminder that we're going to add will help remind people that they have to take their pills after they've had sex. in a similar way, in kind of like they were doing daily reminder pills for PrEP. This is going to be the opposite and reminding you after sex.
That is so cool. And when did you say that that new feature is going to start rolling out on the app?
We will have the new version out will be November 1st. That is our launch date.
Really, really interesting. So someone just asked a follow-up in the chat about the app, whether or not it's transgender friendly.
Actually, yes, we went out of our way to make it transgender friendly.
Thanks so much for that. So Lee, I'm gonna now just take a moment and ask people if they would like to raise their hand and ask a question live on camera. Please go ahead and do that. I will look through the chat to see if there's any questions that may have come up that I missed. But Lee, before we move on to our next speaker, and barring there's any other QA at the moment, is there anything else you want to share about your DoxyPEP, or I'm sorry, DoxyPEP experience to date?
It's really taken a lot of there was a lot of struggle to not knowing whether or not there was anything I could do to protect myself from getting an infection. And DoxyPEP really made a difference in my ability, the freedom that I felt like I had, the not having to worry, the not when I done something that's slightly risky, I feel like I have a choice besides waiting 7 days and seeing what the outcome is. And I really like having that control. It's I thank the scientists who've been working on this all the time.
Thanks for that. And it looks like we do have a question to come on live. So we're going to take that question and then we'll move on to our next speaker, Dr. Khan. But Mark, thanks for raising your hand. Go ahead and come off mute and ask your question.
Yes, good morning. Thank you so much for telling us about your experience. Mark McPherson, pronouns they, them, Columbus, Ohio. My question is, were there any cost barriers or issues encountered in paying for DoxyPEP, such as like insurance coverage denials or high copays or anything like that?
There were no insurance denials. In fact, the Doxy was fairly easy, but it was hard for the doctor to actually prescribe it. Numerous times the doctor was not interested in prescribing me the antibiotics. They didn't know the protocols, even though it had been several months that I'd been on the study. They were resistant to giving it to me. But now it seems like that is not the case, and the doctors are very interested in providing it.
Thank you so much.
Thanks for that question. And we are at time, but I see Bidya has her hand up. So please ask your question briefly, Bidya, and we'll have Lee go ahead and answer that before we move on.
Yes, thank you. Just a video. I work with the UN. So I just want to know, so do you drop condom altogether? That's one. And secondly, what do you do with other STIs? Because there are over 30 there. So thank you.
I still go and get treated. I still go and get tested and possibly treated on a monthly basis to cover to make sure that I have not gotten one. But yes, for the most part, I've given up on using condoms. They were, while they do provide a measure of safety, they do also provide a bigger level of disconnect. I don't feel like I'm one with my partner when I'm using them, and it's much better for everybody if we're not using it. So this is a way of being a little bit more safe while doing that.
Thank you, Lee. And I think, and I really appreciate your comments and your forthrightness. And I think you really bring up an important point at the end here before we move on to Dr. Taimur Khan around sort of the various values and choices we make around our sexual activity. And there's always risks and benefits. And I think we too often don't talk about the benefits of intimacy and pleasure and the things that we can feel in terms of connection with a partner when we don't use condoms. And for a lot of people, condoms can create that sense of barrier not just from other STIs, but barrier to intimacy. And it's an experience that a lot of people have. And that's why we have this robust, agenda to find new ways to protect ourselves that are not barriers. So I just appreciate you bringing that up and highlighting that. Lee is going to stick around and see if there's other questions when we are done with all of our speakers. Lee, please, I think there's been some other questions about your app in the chat if you want to go in and check on those. But I'm now going to turn the floor over to Dr. Taimur Khan from Fenway Health. Go ahead, Taimur. Thanks so much for being here.
Thank you so much, Jim. Jim, is this the correct view or do I have to swap it?
It looks great. It looks great to me.
Awesome. Yep. Thank you so much, Jim. Thanks for asking me to speak. Again, my name is Taimur Khan. He, series pronouns. I'm speaking to you from Fenway Health based out of Boston. And I just want to say, please put questions in the comments. I will try to go through all my slides first. There's a lot of information in here. And then I'll spend the end kind of answering questions. And I want to start off by thanking Lee for talking about his experience. And I think having the discussion based around pleasure and the toolkit we provide to patients is extremely important. I will be talking a lot about the data, but at the end of the day, that is the most important thing, and not to stigmatize or shame patients for their experience and their preferred ways of handling their healthcare. So let's get started. So the agenda today is going to be a quick overview of STI trends. I'm going to talk briefly about what the DoxyPEP studies have shown us thus far, where the data is going, what are the gaps in the data, what we're doing here at Fenway in Boston, and then special considerations if this is something you're thinking about starting off at your clinic. And then I'll touch briefly on the news from this week with the national guidance from the CDC. So I feel like I'm going to be preaching to the choir a little bit, but we know that from the WHO, based out of studies from 2021, that there are more than 370 million cases of curable STIs every year. And within the US, we know that from the data provided to the CDC, that there's been a precipitous increase in cases of gonorrhea and syphilis. And more interestingly, recently, we have also seen cases of congenital syphilis go up in the last few years, which is, garnered a bit of the spotlight because it is something that's very curable. It affects both the mothers and as well as the newborns. So it's something that we are trying to place some focus on now. And the other things I didn't include in the slide are long-term consequences to these bacterial STIs. So with syphilis, you can get congenital syphilis, as I mentioned, neurosyphilis, especially pronounced in our patients living with HIV. And then with chlamydia, you can have infertility issues. And gonorrhea, obviously, there's antibiotic resistance, which I'll touch on a little bit later in this overview. So a lot of questions. I'm realizing from the chat there's a lot of varied experiences with doxycycline and DoxyPEP. So I'll give you some background information. So what is doxycycline? Why are we picking it now? Doxycycline is an antibiotic. It is, as with all antibiotics, not all of them are the same. Doxycycline is in a class of antibiotics called tetracyclines. These are antibiotics, especially doxy, which has been around since 1950. It's been well tolerated, it is safe, it is generic, it is inexpensive, especially the capsule form. And it's not new to our patients. We've used it to treat things such as rosacea, acne, and it is the first-line treatment for chlamydia right now. It is also one of the preferred regimens for syphilis. We do know that there is already, prior to any DoxyPEP initiatives, resistance to doxycycline by gonorrhea, about 20% of them, especially in the US. So it is not used as the first-line treatment. That is ceftriaxone. That is a different class of antibiotics altogether. And we have really good treatment regimens using ceftriaxone at 500 milligrams. So not the first line, but it does have some effectiveness to gonorrhea. How did we get here? So there was a study based out of France. It was called Hypergay. Now, this was a study that was looking at on-demand PrEP for HIV. Within that study, the PIs included a branch of that study that was looking at doxycycline used as post-exposure prophylaxis. And what they found, which they shared in 2018, was that it reduced the cases of syphilis and chlamydia by 2/3. They did not note any significant effects on gonorrhea at that time. And I'll get to this a little bit later. After that, Luke Meyer and their colleagues, and I believe they're on this call, published data at the AIDS conference in 22, as well as New England Journal of Medicine in spring of this year, that concluded that among patients that were MSM, men who have sex with men, and transgender women, they noted a 2/3 decrease in bacterial STIs when doxycycline was used per incidence, per sexual activity within 72 hours of having sex. So if taken within the first 72 hours after having any condomless sex, they notice a decrease in bacterial STIs. They also noticed that there was a marked reduction in all 3 bacterial pathogens, so gonorrhea, chlamydia, and syphilis. The data was more pronounced for chlamydia and syphilis. As I mentioned, those are the doxycycline is used as first-line regimen for those, and gonorrhea has some activity. So this was not surprising, but the marked decrease was pretty pronounced. Colleagues also looked at qualitative data that was published at the International AIDS Conference in 2023. And what they found was from the patients or the participants that loved using this drug, they said it was safe, it was acceptable, they felt empowered by it, there was high adherence. Lee even talked about his own experience with that, which I really appreciated, talking about, having to take a medication once with peace of mind, and not having to take maybe a 10-day course or anything else in addition to that. What are the gaps right now? So a lot of questions are coming up about antibiotic resistance, about microbial flora, like what's going on in our GI gut. And so I'll share with you some of the studies that are coming out and where the studies are going, hopefully. The group that did Hypergate in France, Molina et al., they published some preliminary data on another study they were doing, and that's called DoxyVac. And DoxyVac is DoxyPEP plus a gonorrhea vaccine that is now in clinical trials in the US. And what they found was that it did have effect on gonorrhea, DoxyPEP did. And the other thing they're looking at is other STIs, and the one they put a spotlight on is Mycoplasma genitalium. And this is data that's still coming out, but someone in the chat asked, what about other STIs? And what I will say about that is we know that these 3 STIs are still problematic, and we have a tool right now in real life right now available to us that we can use to treat and curtail some of that trend. And so, yes, there are going to be theoretical other issues. There are going to be other STIs we need to worry about. But right now we have this tool and we're trying to figure out how to use it best. So I really appreciate that these PIs are also looking at other STIs and the effects of doxycycline on those as well. There was a study out of Kenya called DPEP. And what they found was looking at cisgender women that were reporting self-adherence to doxycycline as PEP, that there was no difference. And so these PIs, these researchers were scratching their head and trying to figure out where do we think this data may have come short. And what they found was when patients were self-reporting adherence, they were also getting hair testing done to assess whether or not doxycycline was even found in their system. And what they found on the right side, you'll see, is that amongst the hair tested, they found 44% of the patients that had doxycycline prescribed, they couldn't detect it in their body. So then the question became, oh, is this biology or is this behavior? The hair testing showed that that might be something that we need to look into. So there was another study that was shared at Croy this year. And it was looking at, and this is a lot of data, and I apologize, but the take home from this is that they were able to find significant enough amounts of doxycycline in the blood, in rectal secretions, and vaginal secretions that make us think, biologically, we should have theoretically enough doxycycline to prevent these infections from taking place. So then now we're having additional studies looking at adherence in cisgender women to see if this is equally effective. Next slide. Other questions I've noticed from both the chat as well as my own experience prescribing this medication to patients has been, what about antibiotic resistance? In the last 10 years, we've seen medical societies and hospitals really push for antibiotic stewardship to decrease the amount of antibiotics we give to patients because there's concern for antibiotic resistance. So what I will say is from the studies that we have thus far, the numbers are limited. We don't have a lot of isolates to make vast generalizations about, but the numbers we have seen is that so far, DoxyPEP has not increased or worsened antibiotic resistance. We know already that tetracycline resistance occurs in gonorrhea, and so we're not surprised to see it, but it has not been very different in the cases where DoxyPEP has been prescribed. It is also really tricky to tease that out because people take doxycycline for multiple things, right? So your patients are having a bacterial STI. They may have seen doxycycline recently for a chlamydia infection or syphilis infection or rosacea or acne. So to be able to tease out what is due to DoxyPEP versus other doxycycline or tetracycline exposures is really tricky. But there's some exciting news, right? So if we say that if you're taking DoxyPEP, your rates of infections goes down, the need to give more ceftriaxone, which is the first-line regimen for gonorrhea, should decrease. And theoretically, you should have decreased chances of there being resistance. So that's kind of like the excitement around this. What about syphilis and chlamydia? Now, I've talked about doxycycline being the first regimen, and there's been concern, well, what if we're giving doxycycline all the time? What if we can't use that first-line regimen? The good news is so far, we don't have any clinical documentation of there being antibiotic resistance to doxycycline, not once. And that's partly due to its effectiveness, but also it's really hard to kind of test for that. But clinically, what we've seen is people that have these infections who receive doxycycline tend to do well rather. And the last question I'm seeing come up here and there is questions about how does this affect me? The bacteria, the good bacteria in my body, my GI tract, my skin. And there have been some initial studies looking at the cases of MRSA, so Staphylococcus, when that bacteria that lives on our skin sees a lot of different antibiotics, it can develop methicillin resistance, so that's the MRSA. And so far, what we've noticed from preliminary data is that it has not driven increased rates of MRSA. Could it? Sure, theoretically it could, but we have not seen that yet. And the gut flora is still being explored. I think some of the concerns with doxycycline and the GI issue has more to do with the effect on the upper GI tract rather than kind of like the gut flora that lives further down. However, there's no concrete data to suggest that it does or does not affect it directly. Okay, so who am I? What are we doing with this information? This is a lot of information. So I'm at Fenway Health. We're based out of Boston, across the street from Fenway Park, and we're a nationally qualified healthcare setting and center, and we focus our care to LGBTQI+ communities. We serve about 35,000 patients, and we have got a significant number of patients who are on PrEP and people living with HIV. And so last winter, we received some funding from the CDC and NACHO to start implementing some of this data into our clinic. And the initial work we did was with the help of Michael Traeger, who is a colleague of ours based out of Australia, who took some of our data from Fenway and helped us kind of explore how to design a model or guidance within our organization that would help us to target a specific population, the biggest bang for our buck. And so based off of this study, he was able to look at all patients that we have at Fenway versus patients who may have just had syphilis and every variation in between. What we found was our sweet spot for kind of guiding this right now to prevent future STI infections would be to target anyone who has had a bacterial STI in the last 12 months. This is a model, this was theoretical, this was based off of some of the data we had. And so then what we did was we moved on to creating some guidance. And so in February, we told providers at Fenway, we said, hey, we've seen this data. We're going to inform you about the data, and we want you to think about how you'd want to use this in your clinic. And so we created these smart phrases, and there were 4 categories that we included for providers to think about. And that was, have they had a bacterial STI in the last 12 months? And that's gonorrhea, chlamydia, syphilis. Are they a PrEP utilizer and have had more than 2 sexual partners where they've engaged in condomless sex? Are they a person living with HIV with the same sexual activity? And then we had a catch-all at the end, which is shared decision-making. And this is important because at Fenway, we engage in an informed consent model, which means that our job is to make sure things are safe and that patients are informed, and then they make the decision for themselves. So we give them the data we have, we tell them what we don't have, and we let them kind of decide. So what about assigned female at birth patients? I know this is going to be a question that comes up because the data is not there yet. As long as they're not breastfeeding or pregnant, I just tell them about the data. I say, hey, you just got diagnosed with chlamydia and syphilis. I know you're very sexually active, and that's amazing. and I want to empower you. This is the data I have so far. This is what I don't know yet, but I'm happy to prescribe this to you if this is something you're comfortable with. And so I find more often than not that patients are willing and ready to use DoxyPEP as another tool in their toolkit. But it's not something I flat out tell providers, hey, you should be thinking about this more aggressively or less aggressively in this patient population. What other tools have I provided patients? So I know Lee mentioned that his primary care provider was really hesitant to kind of prescribe this. And I will tell you from personal experience, talking to Fenway providers and people outside of my organization, that it is hard to get providers to do new things without there being the backing of either a board exam or general national guidance, right? And so to make life easier for providers, since they are so strapped these days, it is to create as much streamlined things for the EMR and their patient interactions as possible. So the coding I provided them was this one for exposure to an STI. I created this doxycycline script, which included instructions to have it with water or food and don't lie down immediately so that, you know, it moves down the gut without any issue. And then I created smart phrases for the notes to have so that providers didn't have to type out too much and had like a template ready to go. And those pink sections are drop downs where they can select different options. The last thing I created, which I find still very helpful, is patient instructions, and this is what we created. This is both goes in the EMR, gets handed to the patient, and it's a really great way for patients who don't want to necessarily start taking to think about it. I will start a conversation, be like, hey, this is what the data shows. You can take this, you can look it up, you can research it. We're expecting national guidance to come out for this at the end of the year. But you know, you might not want it now, but it's something you may want to consider. And so between February and now, we had to do multiple trainings with providers, and currently we have over 1,000 patients who are prescribed DoxyPEP. Our numbers have precipitously increased through the summer, and this is some of the demographics. This is pretty in line with what we have as a patient population here as well. But we're just starting to look at data and do surveys of both patients and providers at their experience and kind of like their attitudes towards using doxycycline. But based off of the numbers and the uptrend in patients taking it, I think overall and from personal experience, it's been a positive thing that's happened here. Okay. Maybe this is something you want to do, right? This is something you want to start doing before there's official guidelines out. So what's important to consider? As I mentioned, breastfeeding and pregnancy, it's contraindicated. We've heard a little bit from Lee and from other people who've used doxycycline that can cause a little bit of an upset stomach, and that's true. And we do know that if it sits in the throat for too long, as with other medications, it can cause pill esophagitis. And that just means that you didn't swallow it properly or it didn't make its way through all the way down to the stomach. And so all we say is have some water, sit upright for 30 minutes. As I mentioned, there's no emergency in taking this. You have 72 hours. It is preferred, theoretically, to take it within the first 24 hours, but you don't have to take it immediately. I had a question recently which was from a patient who said, you know, I binge drink a little bit and should I not take it with my alcohol? And I said, you know, you can have it shortly after you sober up or the next morning. You don't have to cause so much insult to injury to your GI tract when you're out for the night. So just wait a little bit and just take it the next day. Although it's extremely rare, hypersensitivity or allergies to doxycyclines is also a contraindication, and also a severe liver kidney disease. That's just because of the way it's metabolized. What else? So what about drug-to-drug interactions? Thankfully, no interaction with hormones or antivirals. So if you're taking PrEP or treatment for HIV, there's no interaction that you need to be concerned about. There are very few you do have to worry about. And that is antacids and iron supplements can bind to the medication, so it won't get absorbed properly. The other drug you might want to just be sure of that you're not causing any issues with is blood thinners, specifically warfarin. And the only guidance we give there is that you have your INR checked and just watch that carefully. And then obviously if people are using retinoids for acne and skin stuff, it can interact with that a little bit. And if you're taking other antibiotics and they're similar, like a tetracycline for some reason, just be careful when you take it and to talk to your doctor because they may be competing for the same mechanism, but that's about it. Getting into national guidance, and I know I'm flying through this, but I'm glad you'll have the slides afterwards, and I'll look at the comments later. But earlier this week, the CDC released for public comment some initial guidance that they've provided. There is a link to that also that includes a video, and from the video you can see that this is a summary of their guidance right now, and it falls pretty much in line with what we're doing at Fenway, which is taking doxycycline 200 milligrams once per sexual encounter with a limit of once per day for gay, bisexual men who, and other men who have sex with men and transgender women with at least one bacterial STI in the last 12 months. Granted, we've got a little bit more leeway. We also provided with informed consent to those who think they may benefit from it, but the data is still out on that, and that is why they have said there's insufficient data for transgender men, cisgender women, heterosexual men, and other queer and non-binary individuals. Whew, that was a whirlwind, but if you have questions, I'll look at the chat and I can take questions without sharing the screen.
That was a whirlwind, but beautifully done, Taimur. So interesting, so thorough. We will take a few minutes, and if you could also, when we're done, if you could look through the chat, there's a number of things we probably haven't been able to get to. I'm also going to encourage the other folks who've been working on Doxy in the room. If there are questions that you can reach out and answer, please do. This is definitely a group effort, and there's a lot happening. So first of all, just in thinking about populations that could benefit, and hopefully we'll get some more data for cisgender women that'll make us feel more confident about use among cisgender women. But someone mentioned adolescents. When might we have information that would be appropriate for people who are adolescent?
You know, I use this example a lot, which is when a new tool or medication comes out, it takes some time for all the nuanced demographics to be accounted for. And for example, when we talked about PrEP, it was MSM populations that we looked at. And now we've advanced to the point where we're looking at on-demand PrEP, infrequent uses, we're looking at adolescents, trans people, so I would say right now, this is low-hanging fruit that they're just putting out some guidance because we know this tool is effective. And now the studies will kind of come off of that. So I don't know who's doing the studies in adolescents, but I'm sure it's being done in some capacity. I know at Fenway, we've prescribed it to a couple adolescents and a few cisgender women and transgender men, and we're going to be teasing that data out as it comes. But I haven't seen anything on it yet, but hopefully soon.
Great, thank you for that. So there's been questions about the timing, and you mentioned it, like when's the best time to take DoxyPEP? Is there such a thing as too soon? So someone was mentioning, like, let's say, I just had sex, I'm on my way home. Can I pop that pill walking home or driving home?
Absolutely.
Is there a too soon?
That's a great question. And I would say, no, there's no too soon. It should be after. From that study that Holland did that was shown at Croy, they were talking about mucosal sampling, and they found that the first 24 hours had the best concentrations, the MICs for these pathogens, specifically for gonorrhea. And that's theoretical. That's not clinically studied, but based off of tissue sampling, they said, oh, there's actually significant amounts of doxycycline at that point. So I would rather have someone do it right after they have a sexual activity versus taking it at hour 70 at the end. So I would prefer that, sooner the better. Also, there's a chance of forgetting. And so if you take it right after when it's at the front of mind, it's not too soon. And again, this is early data. This is based off the theoretical studies. We know that the first 72 hours are a hotspot and they work. But the more nuanced ranges are yet to be determined.
Thank you for that. That's super helpful. So there was a question, so I think I just want to unpack this a little bit more. So Lee talked about having some GI issues that lasted for days. And then, there's a couple questions in the chat about is that okay? Is that fine? That seems like a lot. So do you have a sense for kind of the overall experience among people? Is Lee's experience on one end of the spectrum? Is it common? I guess I just want to know more about how people are reacting to doxy, and if Lee's experience is sort of typical or less than typical.
Yeah, so I have two friends who use DoxyPEP, and they are very sensitive to it. There was one person that was out for a weekend. There was another person who just felt woozy and couldn't go to the beach and felt kind of off that day. That is one end of the spectrum that I've seen. And from the studies, we know that people do get GI upset sometimes, but it's not to the intensity that these three persons that I've mentioned have had it. I think it's multifactorial. I think it depends on whether or not they were eating or drinking alcohol or what their sun exposure was. Do they have any conditions prior to starting doxycycline that may make them more susceptible to it? We know there's certain antibiotics that increase GI mobility. So like azithromycin, if you take it, like it forces you to have explosive diarrhea. And we know that's because of the mechanism of action of that drug. And then we also know that there's some of them it's due to kind of like the changes in the micro gut flora. So it's my short answer is we know it's a side effect. It's generally very mild. And I think for more severe cases of like the ones that Lee is describing, my friends have had, it's kind of more nuanced and depends on the person and kind of how they took it and what else is going on. But overall, based on the studies, sorry to interrupt you, based on the studies that were done here for the DoxyPEP study, they didn't find that generalizably that it was severe. It's very mild in most cases.
And it sounded like Lee mentioned, and Lee, you're always welcome to pop on and correct me if I'm saying characterizing something wrong, but you mentioned taking a probiotic. Is a probiotic something that helps folks manage any kind of symptoms like this? And then I'm just going to tie it into a second question that's come up. Are there any foods that people eat that could be eating before they take doxy or while they're taking doxy that might affect absorption, something that we should be concerned about in terms of the drug being properly absorbed?
I thought that was for Lee. So just the only thing to be careful with is iron and calcium supplements. And if you're someone who takes if you're a bodybuilder and you take all these supplements that are from GNC, et cetera, just space it out by 2 hours. And so we recommend if you're going to be taking a lot of iron supplements or anything that is like unknown what's in it, I would just wait 2 hours and you've got a big time frame to kind of pick that out. And that's mostly for effectiveness, not for like any safety issue. That's because it can bind to the doxycycline and prevent absorption.
Excellent. And I see Lee popped on video. Is there anything you want to add to this side effect discussion since we've been saying your name a little bit here?
I wanted to point out that the probiotic that I ended up taking ended up being what really helped take it so that I could, you took the antibiotic, it was going to mess up your gut flora, but the probiotic kind of alleviated those symptoms and made it a little bit easier.
Great, thank you for that. And I have a few more questions. We're going to be wrapping up soon. I'm going to ask, just 1 second, Taimur.
Yep.
If folks can, if someone wants to ask their question live on camera, please raise your hand now, and we'll make sure to get to you. Otherwise, I do have a couple more questions that we can ask before we move on to Kendrick. But what were you going to say, Taimur? When
I was just looking over the chat, and I'm happy to continue answering questions. But there are a couple of important questions I want to answer because I flew through them in the slides. One is when we prescribe doxycycline as DoxyPEP at our clinic, we give them 50 capsules with 1 refill. That is just what we decided internally. I know other places will do a 30-day supply and have no refills to kind of monitor. But again, we don't want to shame or stigmatize. We provide them with enough. There's a question about the 2 different formulations of doxycycline. There is the capsule, which is and then there's the tablet. The tablet is actually very expensive. And so, but we know from pharmacologic studies that they're pretty much equally effective. And so what we use here at Fenway is the capsule form. And it's very cheap, it's generic. Insurance doesn't need to cover it because it's been on the market for decades. And then the last question I wanted to say was, have there been studies looking at the advantage of DoxyPEP versus DoxyPrep? And yes, before all these studies that were done, there was one study that I think looked at DoxyPrep, so taken daily, and that went by the wayside and hasn't been looked at again since then, but there may be additional conversations about that later. But right now, we're doing on-demand or event-driven regimens.
Taimur, there's a couple of questions about how DoxyPEP intersects with HIV PEP. Can these things be taken at the same time? Are there any issues with someone taking both? Like, how does that work? What do we know about DoxyPEP and HIV PEP?
So we know that it came from that study, right? So the Ipergay study was the one that looked at HIV on demand. Oh, so did you say PEP? HIV PEP?
Yeah, PEP as in
Yeah, so that's a great,
post-exposure
okay, this question
prophylaxis,
came
right?
up, actually, sorry, that's a separate question, I lied. That question came up once before, and what I had, we don't have data. And so PEP studies are very small in number, and they're not great, right? Because we have treatments and we have PrEP, and just there's no ethical way to assess efficacy of a PEP study. Having said that, what I've told people is, these are curable diseases. HIV is not curable, it's treatable. And so while you're taking PEP, I say, avoid taking DoxyPEP just because I don't want there to be so much mixed up with the antivirals that you're taking for that 1 month. And then after that, we'll screen and we'll treat and cure if we need to. And that's mostly my own comfort, just making sure that we're already doing something that is poorly studied, but we're trying to throw a lot of medication at it so you don't acquire HIV. And I don't want to mix that up by throwing in another variable.
Thank you so much for that. And we're going to just pause and see if anyone wants to raise their hand and ask a question live. If not, we will be moving on. We have a wonderful nurse practitioner who's up next. And I will also tease Kate, who works for the National Coalition of STD Directors, is going to be sharing a number of resources from their DoxyPEP STI Command Center that they launched a few months ago, which will have a lot of tools I think people will be interested in having. But before we move on to Kendrick, is there any question that people want to ask live of Taimur? Okay, well, thank you so much, Taimur. This was amazing. Thank you for helping answer questions in the chat. It has been very active in there. So appreciate all your efforts on that. And so without further ado, why don't I'm going to ask to come to the floor, Kendrick. Let me just get all my little tools here and hold on, give me a second. I lost a couple of my boxes there. And there we go. Our friendly nurse practitioner from Houston, Kendrick Clack. Kendrick is someone who works for, I'm going to drop a link in the chat where Kendrick works, but go ahead and introduce yourself, Kendrick, and go ahead and share your perspectives as a nurse practitioner helping to prescribe DoxyPEP.
Of course. Thanks, Jim. Good morning for the opportunity to be a part of this presentation. It's very exciting, and it seems like a lot of people are engaged. So it's definitely an honor to be here and share our experiences. If you hear rain, it's in the background. As Jim said, I'm here in Houston, so we are greatly appreciating this rain we've had for the past 3 days here. But it doesn't take much to flood, so we kind of like have a little fine line. Jim shared the link, but I'm at Crofoot MD Clinic and Research Center. So we're a unique practice in medical practice here in Houston that focus on serving the needs of Houstonians and their friends in the LGBTQ community. We're led by Dr. Gordon Crofoot Jr., who is our medical director and president, and he's been practicing internal medicine for over 30 years, specializing in HIV, hepatitis, and other infectious diseases. Our clinical research center is one of the most respected and sought-after clinical trials locations in Houston, Texas. And so we specialize in HIV and AIDS research, hepatitis C, and other infectious disease studies. And our research and treatment provides patients with access to leading-edge treatment options while delivering optimum results. As Jim shared, Crofoot MD is our website. Check it out and learn more about our practice. So in the short time today, I don't have any slides, but I'll just share how we approach and are doing a DoxyPEP here at our location. So it started a little bit actually after Croy, when the announcement was made and the article was published. 3 of us were there at the meeting, and as soon as we got back, we started receiving phone calls from patients from inquiring about DoxyPEP. So we are a practice of 5 providers. We have 2 physicians, 3 nurse practitioners, and 1 physician assistant, and all are on board with prescribing DoxyPEP. So that's the most important thing is, seeing who all is on board and participating in the intervention. So so our approach pretty much right now, we're looking at patients who are requesting and then more on a case-by-case basis. For example, we have patients that are maybe going on vacation, and they may call to want to have DoxyPEP on hand while they're away. So right now we have roughly 30 to 40 patients between the 5 of us who are on DoxyPEP. So talking a little bit about staff training, it's most important, the staff need to be trained about what we were going to be doing, right? So we have 4 medical assistants, one of which is the clinic manager, and 2 front desk staff. So each week they have a weekly huddle. And so during one of those huddles on Tuesday, the clinic manager basically gave updates on DoxyPEP and let the staff know that we are doing this so that they can get them scheduled. So as I said, we wanted our approach to be a little patient-centered. So we kind of thought about how could we logically implement this so they won't disrupt routines that are already in place, and also stick to standards of care. So most of our patients are already coming for quarterly testing because they're on PrEP, or every 2 months, depending on which formulation they're on. So we kind of start with like 30 tablets with 15 doses over that time period. Sometimes we may need to do gap refills to get them to that next appointment time, because we don't want to make it an inconvenience. But most importantly, we do ensure that the screening is done on at least a quarterly basis to identify as treatments needed, and also advocacy of the intervention. The only caveat to this is that our patients living with HIV, they're accustomed to a twice-a-year visit. So this there has been a change for them, but there hasn't been any pushback for that. So another important thing is we're writing their prescription. So that was definitely a challenge on how to write the prescription so that everyone would be able to understand it. And so the San Francisco guidelines were the first source that we looked at to kind of give guidance on how to write it. So we pretty much mimicked it after that. The doxycycline 100, and we used a capsule as well, and take within 24 to 72 hours after condomless sexual activity. And also remind that do not take more than two tablets within a 24-hour period. And so this SIG, or this prescription, was saved in the EMR as a favorite, so they don't have to type it each time. Just go in, click a couple buttons, and it's more efficient and helpful for the providers. Sometimes the dose instructions have to be revisited due to confusion. So I found that the first time when I had a patient call back for a refill in 2 weeks. And so we had a conversation like what happened. So they were taking it, they thought they would take it for a week. So we basically revisited how the instructions were. And thanks Taimur for what you mentioned about 3-2-1 messaging. And if it's okay, I like to share that with patients, because I find it to be very easy to digest, the way you laid it out in 3-2-1. So testing. So we continue to do our, we have an order set. We've already had an order set in place for STI. So we can just continue to merge that and use that same template with the testing for screening for syphilis, gonorrhea, chlamydia at all 3 sites at each visit. Of course, we do a baseline at the beginning to make sure that all the tests are negative before starting. One of the challenges that we anticipate we do have some patients who are remote. And so getting swabs will be a challenge because the lab sites don't necessarily do them. So more likely, we have found that if we send them the swabs and they bring them in, that they'll run those. So it's probably how we'll be doing the patients who are remote to get swabs with them. So patient testimony, I have had a couple of patients who have been very appreciative and thankful for us doing the DoxyPEP. I do have a couple who have actually, in the short while, have seen they have had multiple positive results, and this most recent time they did not. So it seems it has been effective with them and has reduced their anxiety as well. Side effect profile, I haven't seen much GI side effects with patients. It's been tolerated very well. Haven't had any issues with acquiring through insurance. Also haven't had any calls from pharmacy about the way the prescription was written, which I anticipated we might have as well. So that's been a surprise. So it's been a pretty seamless a pretty seamless implementation here in our clinic. We're very small. We have small numbers now, but we anticipate them to grow. So next steps essentially is doing a full template. We don't have Ethic, we have ECW to build the template in, and then we'll launch that. And then also we have the research patients, and so also seeing how we can implement that or make DoxyPEP available for research patients who PCPs may not be offering it, because right now in the city, we know that a couple of FQHCs are, but the public health authorities aren't offering it at this time, to my knowledge. That's pretty much all I have. Any questions, I'm open to answering. But again, thank you for the opportunity to share what our experiences have been with our implementation.
Thank you so much for that. So much really practical, useful information, real world information. I love how it's really exciting to me that right after these things were talked about at the CROI conference earlier this year, that you were hearing from people right away. So that just gives me a special little buzz. Like, there are so many folks in our community who are really paying attention to science and research and figuring out how to bring that into their own lives. And kudos to you and your clinic for jumping on board really quickly and starting to make things happen well before, you know, there was any guidance. And as we all know, the CDC only just this week released draft guidance, which we put some links in the chat. So really thank you for your experience and sharing that, Kendrick. Would anyone like to ask a question live of Kendrick? If you would like to do so, raise your hand. Otherwise, we will move on to Kate and then bring everyone back once Kate has shared a number of the resources that they have from the Coalition of STD Directors. But any quick follow-ups for Kendrick?
Jim, I did have a quick question. Just
yeah, please go ahead.
You mentioned the GI upset, and for lack of a better word, being out of commission for a couple of days. And one of the things I just want to pose is, when weighing knows the potential, I guess, possibility of having an STI and having to take it for longer, what thought processes does he go through with the I guess negotiating the side effects of the dose for the one time versus the dose for potential 7 or 14 days, depending on what the result was.
Thank you for that. So I am going to move us along. Kendrick, thank you. Kendrick's going to stick around, and Lee and Taimur will all have a chance for some more QA and comments when we are done. But I'm going to now turn it over to my colleague at the National Coalition of STD Directors, who helped co-sponsor this webinar. And she will be walking through some of the resources that they've developed.
Thank you so much. Let me just take a minute to share my screen. And Jim, if you could just give me an okay that you can see this.
I see it and it looks beautiful. Thank you.
Awesome. Thank you so much. All right, so we'll get started. Thank you so much again to Jim and the Choice Agenda for this opportunity to collaborate and come together to discuss this really important intervention. I've really appreciated all of the discussion happening in the comments and live. I feel like a lot of the resources that NCSD has created that I'm going to highlight today are going to really complement some of that discussion and hopefully offer some guidance for some folks wanting to implement this intervention. Excuse me. So I know I said a quick hello at the beginning, but my name is Kate Shea. I use she, her pronouns, and I am the Senior Manager of Clinical Programs at NCSD. Just going to give you a brief background on NCSD before we roll into the command center. NCSD's mission is to advance effective STD prevention programs and services in every community across the country. And as the voice of our membership, we provide leadership, build capacity, convene partners, and advocate. NCSD represents 5,600 STI professionals, including people who run and work in state and local STI programs, DIS, and more than 1,400 clinic members. So to get things started, just some perspective on how we got to the command center. In May, we had our STD Engage conference, and we hosted a plenary session on DoxyPEP implementation. And to our knowledge, it was the first implementation-focused event. We had panelists who were already providing Doxy as STI PEP, and we took audience questions. So from that event, it was really clear that we needed to create a place where people could exchange information. And we created the command center in response for that ask. We knew the CDC guidelines were months out, that clinics wanted to move forward, that other clinics had helpful information to share. So I'm going to just walk you through some of the contents of our command center, a lot of tools and templates that are there free for you to use. And I also want to just briefly acknowledge the draft of the CDC guidelines that were released early this past Monday morning. I saw some comments about that in the chat. They are open for comment, and NCSD will be submitting comments to the draft and eventually updating our DoxyPEP command center to reflect those official guidelines. So definitely stay tuned on that. So to start, the Doxy as STI PEP implementation toolkit was designed to help communities begin the process of offering Doxy as STI PEP to patients based on evidence that already supports its efficacy. And this is, of course, prior to the CDC guideline release. The toolkit combines existing lessons learned from those clinics already using DoxyPEP, as well as broader lessons learned from the implementation of other new sexual health biomedical tools like PrEP for HIV and the Jynneos vaccine for Mpox. And we also include important considerations for health equity within this toolkit. And this is a master PDF that's available through our command center, and we'll take some time to click through the tools that are featured both within this PDF and our command center resource page on the NCSD website. So from the command center, you'll have the option to click through those tools and templates as I talked about. This is what it'll look like when you get to the command center page. And here's a little just a little preview of what some of those individual resource links are for those tools and templates. One that I want to point out is the Quick Start Guide, which is a comprehensive checklist for clinics and sites developing their policies and procedures. This specific guide includes considerations for workflow integration, gathering community input and guidance, questions to consider for program evaluation, and points for developing and using culturally reflective patient education and awareness materials. Moving to the marketing tools that we offer through the command center, these are resources for folks to begin promoting that they're able to offer Doxy as STI PEP to their patients. These tools feature a social media and marketing toolkit, as well as downloadable graphics sized for social media, plus printable graphics available to size for info cards, flyers, and posters. And what you see on the screen here, these are just two examples, but we have several more just as cute as these, and all available in English and Spanish. And we also encourage folks to share the materials they're using to promote their program if they'd like. We do have a Doxy as STI PEP email address for resource sharing and questions and comments that I will share at the end of my presentation if you'd like to share any of your resources. And finally, we also included a toolkit featured for health equity considerations. We know that there's a lot of stigma and misinformation around this intervention, not unlike the introduction of PrEP or the Mpox vaccine. So developing a Doxy as STI PEP program in any jurisdiction should be really intentional around this. And this toolkit specifically details considerations related to existing barriers to STI services, being transparent in messaging, engaging the local community, and educating other medical providers and pharmacists in your area. And I know that Lee specifically talked about his provider struggling with prescribing initially. And we do have some things in our toolkit that are related to this. One is an overview just for pharmacists and providers. One is a letter that could be drafted to local pharmacies. And those are some resources that could be really helpful in just increasing that education. So if it hasn't already been done, I am going to put the link to the command center in the chat so that you can just access and click through as you'd like. If you have any questions, resources to share, or comments to make, please reach out to us. I've included my email on this slide, as well as that NCSD Doxy as STI PEP resource email address that I referenced. And thank you again so much for your time.
Thank you, Kate. That was beautiful. I'm gonna ask all of our presenters to come back on screen, and let me include you in the little, so we can all see you nicely, beautifully. Yes. While I'm doing this, I want to give a special shout out to Dr. Rodney Perkins, who is in the room and has been helping answering questions. Rodney has been involved in this research for quite some time, a central figure in making this research happen and give the results that we have. And Rodney was also directly helpful on this webinar and actually helped connect us with two of our fabulous speakers. Lee and Kendrick were connections through Rodney. So I want to give a special shout out and some love to our friend, Dr. Rodney Perkins. Thank you so much. So now we have all of our panel here, and it's I think it would be great to see if there's anyone who has a question that they would like to ask live and in person. Please go down and in the reactions, raise your hand to do that. And while we're waiting for people to address their shyness and raise their hand, I know there's people in this room who are not shy and have things to say. Thank you. Caitlin, nice to see you. Go ahead and ask your question.
Hi there. Hi, everyone. Thank you so much for everything today. And I apologize if I missed this in the beginning of the webinar. I was wondering if there was any discussion on barriers with either billing or coding or insurance coverage, or if I know I heard the mention on using the capsules to kind of cover this in a more cost-effective way, or if this is being kind of leveraged through 340B programs or other kind of cost sharing from the clinic to ensure that folks are being able to pay for this sustainably.
I can quickly share. Yeah, go ahead.
No, I'm sorry, saying thank you. Go ahead, Taimur, and if you have anything to add, Kendrick, please feel free.
No, and someone in the chat even asked about the comparison of the cost of the drug based, I believe they're in Canada, but like what it's like in the US. And as mentioned, the capsules are very cheap. They're generic. In terms of the billing for this, it is billed as exposure to STI. It's just billed as a regular sexual health encounter. And so I have not heard of any issues with the insurance part for the visit itself. It really shouldn't be. And the drug itself is very cheap. And as you mentioned, there are two different formulations, and we do use the capsule because it is very cheap.
Anything else anyone wants to add to that for that question? Great. I just see there's a question that just popped up at the very end of the chat here, that or current end of the chat, about has there been any pushback from folks concerned about AMR, I'm just going to say AMR resistance. So the question is there any pushback from AMR stewardship experts from the CDC regarding the CDC recommendations on DoxyPEP, and how are we managing that? So anyone want to speak to pushback regarding antimicrobial resistance? There, I got it up this time.
Fun fact, those stewardship experts are the same people that have insight onto the DoxyPEP rollout. So infectious disease specialists are the ones that are in the rooms and are also providing feedback to the guidance and the studies that are being done. So it is a concern. It is a spotlight in all the research that's being done, but thus far there have been no concerns for driving additional resistance. Someone in the chat asked about C. diff infections. It's actually been shown to be protective or have no effect on C. diff in other studies. Not all antibiotics are the same. There are different classes, and doxycycline has very few resistance issues thus far that we know of. And so, yes, it is something we're thinking about. Yes, Stewardship experts are weighing in, but so far, no, there has not been any significant data to suggest that it is a driving force to make things worse.
Thank you, Taimur. I see a question from Amy. Amy, go ahead and unmute yourself. Come on video if you'd like and ask your question, please.
Thank you for this great presentation. My name is Amy. I'm from Namibia. I'm also a nurse by profession. I just wanted to find out, I didn't hear anything about the baseline test. Is there a baseline test being done on members that or clients that want to start DoxyPEP?
Yes, we do baseline testing for everyone at the very start before starting.
What is the baseline test that you are doing in the beginning?
I'm sorry, we do syphilis and 3-site gonorrhea chlamydia.
So if it's a new patient, as Kendrick mentioned, we'll do the 3 sites, so oral, rectal, urine sampling, and then syphilis testing with blood. And because they're at our site and where they're coming in for some sexual health stuff, if there's no HIV screen in the chart, as well as a liver and kidney function, just to screen for the ability to metabolize the drug, and that's it. Basically a prep visit, essentially. An HIV prep visit is what entailed.
Thank you for that. And I'm going to ask a question while we see if there's others who may want to come and raise their hand or put something in the chat. This came up in people when they were sharing their concerns about DoxyPEP. And there was a few folks who noted that they had concern around the rollout, starting with gay and bisexual men. And we saw when we rolled out PrEP in the beginning, there was a strong focus on gay and bisexual men, to the point that other populations didn't think it was a intervention for them, right? They just thought it was strictly for gay and bi men. So what do folks think about the way we're rolling it out now? We're starting really with gay and bisexual men and transgender individuals, but cisgender women, it's still unclear. So what are our thoughts on ensuring that we will have broad access for all the populations who need it? If we're sort of starting where we are, will we run into the same kind of challenges that we've seen with our ongoing challenging rollout of HIV pre-exposure prophylaxis? And maybe this is something, Kate, you'd want to weigh in on, but I think any one of you who want to speak to this would be great.
I think when Taimur, it was my first time seeing the data regarding the uptake and the concentrations in regard to the Kenya study. And I think that gives a lot of information for providers to make a more informed decision. And I'm not against prescribing to individuals who are not MSM or transgender women, because again, that data shows us that there may have been some adherence issues involved with this. And so more investigation needs to happen. And so at the end of the day, we're not doing more harm, and that's what we all strive to do no harm. We're trying to find more. And I think that approach is sufficient.
And anyone else want to weigh in on kind of starting with gay and bisexual men? And if we have all this energy around this, will it potentially derail efforts for other populations? Any other thoughts people want to share?
I was just going to say, I think it was a natural course for that. I can't speak for all other studies like PrEP, but I will say, because this was nested in within the hypergay study, it was like a easy target to start working on very quickly. And so I think the natural course of this happened in that way. I think the fact that they at least had transgender women as part of this study showed some intentionality around diversifying some of that population. But I think, all studies start off at a certain point and they kind of progress. So I can't speak for the kind of like the culture or the intentionality of this, but I can say it just made sense the way they did it. And I appreciate the fact that they expanded to transgender women for the study.
Thank you so much for that. And Amy in Namibia, it looks like you have another question. Go ahead.
I think in terms of Namibia as a country, how I think we could roll it out. For example, the ED prep, we went for a case study to Swaziland last year, and we learned more about ED prep, but it was more basically placed in terms of a gay man, MSM man, or it was also say transgender women who are not on any hormones. But when we came back in country, because of currently the policies and also the lawmakers, also the wording that we are also going to use towards them, we rather say that this is suitable for cisgendered males. For example, for us to get buy-in from the government also, but also from a public health perspective, when we go down on the ground, we talk about more about transgender women, more about cisgendered persons, and all the things that go about. So for us, it's more about the language, how we use it, because the moment we just start a gay man, transgender woman, there's pushback from the government in country.
Thank you for sharing those remarks and including kind of your strategy and how you think about messaging to different audiences and how you kind of make things happen in climates that are not always super supportive of various populations. And I will say, in the United States, we have some serious issues with a lot of anti-gay, anti-LGBT, anti-trans sentiment happening here. We're going to take one more question live from Kirk, and I'm going to have all of our speakers start thinking about giving us one nugget to leave with. So you can only give one nugget to our webinar registrants here. One thing to remember out of all the things we talked about regarding DoxyPEP, think about what that nugget is. And in the meantime, I'll ask Kirk to come off mute and online and ask his question, please.
Thank you, Jim, and thank you, everyone. I appreciate this webinar this morning. I wanted to follow up on some points briefly that Kate had made, and comparing DoxyPEP to both PrEP and also the Mpox vaccine. We're thinking about equity and stigma and ensuring that populations that don't always receive these new technologies get to receive them. And I'm just curious about what efforts, if any, that the panel is aware of that are underway to really address this issue of equity.
Did you want to take that, Kate?
Yeah, I'm sort of pondering. I mean, I can speak to what we have included in our toolkit, certainly, and I think it's difficult to say on a broader scale because each community is so unique in what is needed, specifically for marginalized folks too. So I think really taking into account implementing this intervention within your community and taking things like community what's the word I'm looking for, like community guidance council groups, committees, really taking your community's perspective into account, I think is really important in this, because unfortunately we aren't always offered the tools on a grander scale and from our government, if that makes sense.
Thank you, Kate. Obviously a lot to unpack there and ongoing work that we all need to be doing. I am going to go around now and ask for those final tasty nuggets as we look to the end of this webinar today. And I'm going to start where we started. So I'm going to start with Lee and then go to Taimur, Kendrick, and Kate for the last word. So Lee, you're in the hot seat.
I wanted to thank everybody who's made DoxyPEP a priority. Giving me additional tools to work with to maintain my own quality of sexual health is very important. The Bigger Blacker book does a good job of reminding me to take these medications and keep track of when I do. But without this kind of treatment plan, my options would have been very limited. So, continue the great work that you guys are doing here. The more options that we have, the more likely I am to have a good sexual health, good sexual health. With the more options, the better off that is for everybody.
Thank you, Lee. And thank you for your work with Bigger, Blacker Book. And I should also say thank you for waking up super early to be here today. Lee is in Seattle, so he joined this webinar before 6 a.m. Seattle time. So pretty damn early. I appreciate you showing up and sharing your story. So next, let's go to Taimur from Fenway.
Yeah, again, thank you to the organizers and Jim and everyone, all the speakers. Two things come to mind. One is trust your patients. Let them decide, give them the information that you have and trust, and let them make the decision. And number two is weighing pros and cons on real evidence versus theoretical risk. I think we will learn more about this. That's bound to happen. We will change policies. That's bound to happen. But I think looking at what we have right now is a real issue, and thinking about the real benefit versus the theoreticals is also important as well.
Beautifully put. Thank you. And thank you for, again, your excellent work and for doing such amazing, groundbreaking stuff around putting up a Doxy program at Fenway. So to another part of the country, to Houston, where it has been raining for days, hopefully not to flood stage, but the rain that you want. Kendrick, what is your last nugget?
Yeah, so we have an opportunity to implement a drug that we're all familiar with that is not cheap, unlike when we rolled out PrEP, when we had so much other things involved with it. So consider this as a tool for everyone that comes either ask for it or someone who you think may benefit. And as Taimur said, we're going to learn more about it, but this is a drug that we're all familiar with. It's not new, and all the red tape that's involved with PrEP we don't have. So let's maximize the opportunity to make this a great.
Excellent points. Here. Thank you, Kendrick. And for the last word or last nugget of juicy goodness, I'm going to turn that over to Kate Shea of NCSD.
Yeah, I think thinking on health equity, and like Kendrick makes a great point, this is not a new drug. So normalizing is so important. Just increasing the awareness of this intervention itself. And I think the main nugget I want to share is just the importance of transparency and messaging with patients. Just there's, often a lot of medical mistrust for so many different reasons. And I think that's number one.
Thank you for
Jim, you're muted.
Thank you so much. I've been like babbling away on mute. So sorry. So I'm going to say it one more time. Thank you so much. I would hope everyone please give some love and round of applause to our wonderful speakers in the chat. Thank you all for joining us, sharing your wisdom, your perspectives, and helping us better understand DoxyPEP at this really exciting time. And we couldn't have timed this webinar any better with the CDC finally coming out with its draft guidance this week. So let's continue to watch this space. As everyone has said, this is ongoing and we will be learning more, and hopefully the Choice Agenda and our partners will be able to come back at some future date with some more updates and some more information and answering some of the questions that we don't really have answers to yet. So again, thank you all. I hope to see you at our webinars on decolonization and that wonderful study that's called HPTN 096. We're doing both of those webinars in the first part of November. You'll be getting some information following up on those in an email. In that email, you will also receive a link and an update when the resources from this webinar will be available. So again, we'll have the recording, the slides, and we'll have a resource document that has captured all of the links that were shared in the chat today. So you can go back and check through those, click through those, dig in deeper, follow up with folks who were here. But with all of that, I'm going to again thank everyone, thank all of our registrants, thank all of you for joining us, for hanging out for 90 minutes this morning, this afternoon, this evening. And wherever you are, go and have a wonderful rest of your day or evening or tomorrow or whatever that looks like. With that said, I'm going to officially close this webinar. Thanks again. Have a great one.